All right, so let's look at the next section. We're going to talk about medication administration in pediatrics. First of all, pharmacology. You need to know that absorption can be faster or slower, and that can depend on the route and the age of the child. So there are some differences beyond just being smaller. Distribution depends on how mature the vascular system is. So when they're younger, their vascular system is not completely mature. They may have some areas that are less perfused. Metabolism depends on the liver maturity, and excretion depends on kidney maturity. So meds can either be metabolized faster or slower. A medication safety, always do the 5 rights, always check with allergies. Tissue integrity is an issue because there is less tissue. So when you're looking at parenteral medications that could be damaging to the underlying tissues, make very, very sure that your IV is where it's supposed to be. Be really cautious with those potentially damaging meds. Also, an IV infiltration can impair tissue integrity. An IV infiltration of 50 milliliters in an adult's arm, it's really not, they're going to absorb that. That's really not going to be a huge risk. 50 milliliters in an infant's arm can be a lot. It can be enough to impede perfusion. So we need to be really cautious with that. Because of that, and because of the risk of fluid overload, we are much more cautious with baby IVs, pediatric IVs. Dosage calculation for kids. There's an increased risk of injury if there's a dosage calculation error, because that may be a much bigger error in relation to the child's size than if we made a similar error in an adult. So we're more worried about med errors. Pediatric doses are based on weight, body surface area, and maturation of organ systems. Typically, there are some meds that we don't know what the optimal dose is for pediatric patients. So there are some ways to calculate that. But we need to make sure that we're calculating doses correctly. You can look up safe dosage ranges, safe and therapeutic dosage ranges for a lot of medications in the Davis drug guide for pediatric patients. So you can look up for, if I'm going to give ceftriaxone to a child, what is the safe and therapeutic range for that child? The oral med route is preferred in children. This is the least traumatic way to get meds in most of the time. Milliliters is the preferred measurement. Meds should be measured in a graduated medicine cup or in a syringe, not in a kitchen spoon. We can do a lot of things to make meds more palatable. Some meds are very bitter or have a taste that's really, some of them just taste disgusting. But if the med doesn't taste good, we can do things to make it palatable. But whatever is added to that med to make it palatable does not need to be an essential food. So we can mix a medication with, there are commercial syrups that you can buy or that pharmacies use to mix. So we can do that. Some people will mix meds with, say, chocolate syrup or something like that, or in soda. You don't want to mix med in formula or in any food that you want the child to not reject. Because if the food taste causes the child, or if they can still taste it, they can actually reject that, whatever it was mixed in as well. And we want to mix those meds with a small volume. You don't want to take 5 milliliters of medicine and put it in half a cup of juice, because if they don't drink the whole half cup of juice, you actually haven't given the whole dose of medicine. So they need to be mixed with a small volume. When we're giving oral medications to an infant, they need to be given in a syringe. You want to hold the baby upright or semi-upright, and you use the syringe without a needle, clearly, to place a small amount at a time in the side of the mouth. There also are nipples that can be used to administer medications. If the child can drink from a cup, you can use a medicine cup, but the easiest is typically a syringe. For older children, when we give oral meds, you need to be honest about the taste. Don't tell them it tastes good when you know it tastes bad, because they're only going to believe you once. Okay. And then they never believe anything else you say. Allow them to choose their chaser and don't give false choices. So don't say, do you want to take your medicine? Tell them it's time to take your medicine. Subcutaneous route. We want to choose the appropriate site for the volume. Make sure that we're choosing a site that can hold the amount of volume we're giving in that injection. Choose the appropriate needle size. A sub-Q for a child needs to be pretty little. If you use a needle to draw out medication, change to a different needle. And if, when possible, there are topical numbing creams that we can use to numb the spot before the injection. For intramuscular, use a topical anesthetic if at all possible. Use the appropriate size needle. So I want you to think about, typically we want to use an inch to an inch and a half needle for an IM on an adult, depending on site, right? If you use an inch needle on an infant, you're going all the way to the bone. So you're going to use the needle in an infant to give an IM that you would use for a sub-Q in an adult. So think through those things and choosing the appropriate needle size. If you use a needle to draw out medicine, change it, and then make sure that you're choosing the appropriate site based on muscle development, the volume of the medicine, and the viscosity of that solution, and on how you can position that child safely. The most common IM sites for really young children are going to be vastus lateralis. Sub-Q and intramuscular tend to absorb more erratically in children. So those are not our favorites. If we have a kid that needs some antibiotics and we've lost the IV, rather than stick multiple times for an IV, we might do injections, but we really do a lot more oral or IV. So intravascular, we want to use a topical insertion cream for insertion if possible. That's not lidocaine injection, because that's still a poke. So use a topical insertion cream for that insertion. Should they have a peripheral line or a central line? Think about the risk and benefits of both of those and when it might be a good idea to request a central line. If they're being stuck over and over several times a day to get a peripheral that keeps flowing, then they might need a central. But if they're just in the hospital for fluids, a peripheral should be enough. Remember IV safety. There's a greater risk of fluid overload, and also if that IV infiltrates, there's a lot less space for the extra fluid to go into. So we use smaller bags, and we also use what's called a Buretrol. So let's look at a Buretrol. If you've never seen one, gonna find an image. It's not wanting to load. There we go. Okay, so let's look at this Buretrol. So this is a Buretrol tubing. There are Buretrols that don't come with tubing. You add them to the tubing, but here's where the bag is spiked. The fluid goes into the Buretrol, and then it goes from here into the child. So if you notice, there's a clamp above the Buretrol. So you put a certain amount of fluid into the Buretrol, clamp it off, and then when your IV's running, this is the only fluid that they can get without adding more to the Buretrol. So it's an additional safety mechanism. We typically don't want to put more than 2 hours worth of fluid in the Buretrol at a time. We actually go a little over 2. We want to set it so that we're checking it at least every 2 hours. For smaller children, you want to check it every hour. And the reason you put, say if your IV's going at 20, 40 would be 2 hours. If you put 50 in there, then when you go check it at 1 hour and 2 hours, your Buretrol's not empty. You don't have air in the line to clear out. So we want to go just a little past that 2 hour mark, set our pump for 1 or 2 hours to go back and check it. So we're checking that frequently. Okay. We also want to look at the tonicity of the fluid. Small children, they have a greater body water. So we typically are going to give quarter normal saline rather than normal saline or half normal. And we give them if we give them what would be an isotonic fluid in an adult, it actually pulls water out of their tissues. So we want to give a lower tonicity. And we want to look at infection risk and tissue integrity. Rectal administration can be used for a couple of different reasons. It can be used to give meds that would be given orally. There are rectal formulations of some meds like Tylenol and some anti-epileptics if the child is vomiting, having a seizure, or won't cooperate. So we can do, we have a few things we can do that way. We may also give laxatives or other locally acting suppositories. If you're going to split a suppository dose, you cut it in half lengthwise, not crosswise. Okay. Insert the pointed end first, push it past the sphincter, hold the buttocks together. Optic and nasal are administered similar to adults. Ear solutions for under 3, and I think I said this backward. I thought I did when I said it when I was talking about the tympanic thermometer. You want to go down and back for under 3, up and back for everyone else. Okay. All right. Next section we're going to talk about is pain management and communication with kids.